I really think if you're very careful and thoughtful and competent and intentional and mindful about how you're working with this patient, that they come into your office and they spend that time with you, and I think that can be a form of contemporary asylum. I'll tell you what isn't a form of contemporary asylum is just medication. And I'm not anti-medication, but I am stunned and shocked and mortified at the extent, in our country at least, of how the first response is to, especially with kids, for whom the effect sizes and the empirical support for the use of pharmacology is much more marginal, are taking 3, 4, 5 different kinds of major psychotropic medications and may never have even seen a psychotherapist. There's a referral I got 2 years ago of a mother, really outstanding young man who was very severely depressed, tried on 6 different medications, was refractory to all of them, ultimately went to Johns Hopkins for ECT, which helped him, but she was worried about relapse, and he had never ever seen a psychotherapist. 16 years old. So you really do see this is not wildly aberrant. And the managed care companies really look at this, and I don't mean this to sort of bash managed care, but they look at a model whereby a primary care provider might prescribe medicine and then make an appointment for 6 to 8 weeks later. That's a pretty cost-effective model. The bad news is patients don't take the medicine as prescribed. They don't fill that script. They don't typically get the therapeutic doses. They don't get the medicine into their bloodstream for it to even work because they still have to take it reliably. And then most won't attend their follow-up appointment. So while that may be a cheap solution, it's not viable. It's not viable.